Oh, thank you so much for taking the time and being up with us today on this first of the month's webinar. The topic on for today's webinar is on natural killer cell therapy, a very key component of our impact or immune personalized autologous cell therapy program. And we have with us the main man, Dr. Francisco Contreras, Chairman and Medical Director of the Oasis of Hope Hospital. Doctor, you've been around Oasis oncology patients for about 40 plus
years, yes.
47 years. I don't want to age you, but he is an expert in cancer treatment. He's a surgical oncologist, and he's with us today. And my name is Gaston Tesada. Sorry for that. I am the director here of the Oasis of Hope Hospital, and I've been working here for about almost 20 years now. And it's a pleasure to be with you here today, tomorrow, this morning, this afternoon, wherever you're part of the world. Will you give us a quick shout out of where you guys are from? We always have a very mixed audience from all over the world. We have from Jamaica, Oral from Jamaica, amazing. Robert from London. Janelle, Mike, going so fast.
London, England, or?
London, England, yeah.
Wow.
Yeah, from Tucson, Arizona, from Belgium, from California, from Cincinnati, Costa Rica, Ruth from Philadelphia, Dr. John Montalvo, I recognize you. Vincent from San Diego, Rick Hill from Rick. Thank you so much for taking the time. Monica from Virginia, from the Philippines, from Vancouver, all over the world, Dr. Contreras. I think everybody loves you.
Thank you. Thank you very much for honoring us with your presence.
We're going to begin with a quick presentation on the natural killer cell therapy by Dr. Contreras, then show a quick video of the program, and then get to the most famous part of the webinar, which is the Q&A. So
are we going to be showing a...
Can we show the video first?
Yes,
yeah, let's show the video first.
That would be
all right, give me a
the best way to do it.
All right.
Natural killer, or NK cell therapy, is a key component of the Impact Immunotherapy program at Oasis of Hope. NK cells are a vital part of the immune system, the body's first line of defense against threats like viruses, infected cells, and cancer. Unlike other immune cells, such as T cells, NK cells don't need prior exposure to a specific threat to take action. They can respond quickly and broadly, making them especially valuable in cancer treatment. NK cells recognize when something is wrong by scanning for signals on the surface of cells. Healthy cells display certain self-markers that tell the immune system not to attack. Cancer cells often lose these markers or express abnormal patterns. When NK cells detect these changes, they launch a direct attack, destroying the abnormal cells. This built-in ability to target a wide range of cancer cells without harming healthy tissue makes NK cell therapy a powerful and natural way to support your immune system in the fight against cancer. Step by step, how NK cell therapy works. Step 1. Collection. A small sample of your blood is drawn to isolate your natural killer cells. Step 2. Activation. In our laboratory, your NK cells are exposed to immune-activating proteins called cytokines. These signals stimulate the cells to become more aggressive and precise in targeting cancer. We multiply the number of NK cells from thousands to millions. Step 3. Personalization. Your activated NK cells are further trained to recognize specific markers found on your tumor cells, increasing their ability to target cancer while sparing healthy tissue. Step 4. Reinfusion. The activated NK cells are returned to your body through a simple infusion, where they immediately begin patrolling and attacking cancer cells. Step 5. Integration. NK cell therapy is often combined with other treatments in your metabolic protocol, creating a personalized, multifaceted immune response designed to maximize therapeutic impact. With natural killer cell therapy, we are equipping your immune system to do what it was made to do: recognize, reach, and eliminate cancer cells.
With the natural killer cell therapy, we are equipping our patient's immune system to recognize the tumor so that it can be destroyed in a very natural and powerful way.
All right, we're back. Thank you so much I hope you enjoyed the video. We're going to start off with Dr. Contreras' presentation. And in the meantime, while he's giving his thoughts, if you want to begin asking your questions either through the webinar chat or the Q&A section of the site, we try to get to as many questions as we can, but the sooner you put in your question, the most likely will get answered. And I want to give a special shout out to our patients that are in the infusion room right now viewing the webinar. Hello, hello, and Dr. Contreras, take it away.
So it's important for us to view our immune system as a mechanism by which our body has a number of elements and a big arsenal to defend our body. Very similar to how a country defends itself. So they have the Army, the Navy, the Air Force, and then they have certain institutions like the police force, the fire department, and then you have institutions like the FDA, the CDC, and all of these agencies that are supposed to be there to protect us. And so one of the very specialized areas of our immune system to attack cancer are the natural killer cells. And they're part of the T cells, and the T cells are part of the white cells. So we have a very varied family of white cells, and each group is specialized to attack a certain element or foe. So the immune system will attack cancer cells as long as it's able to see them, and in many cases to be presented, though the natural killer cells do not need the presentation that other white cells need. But still, it has to be able to see the tumor. And for that purpose, natural killer cells have to be activated. And we activate them, as the video stated, with some enzymes, with some elements of the immune system, and also with antigens. And this way, these elements can attack tumor cells. Natural killer cells, though, need a longer time to expand. And the word expand in the immunological lingo means to proliferate or to sort of clone them. So we obtain maybe 100,000 cells from the patient's blood system or blood, and then we expand them in the lab to millions. The average is around 10 million, but when we're able to simulate them even more, we can obtain up to 50, and in a few cases, we've obtained close to 100 million. So the more killer cells that we are able to reinstitute into the patient's blood system, the more aggressive the attack is going to be to the tumor. So natural killer cells, it's not always possible because the patient will not have so long a time to spend with us. And but when they're very important, what we will do is that we'll obtain the blood, the patient goes home, we expand them in these 2 to 3 weeks, and then the patient is going to call back once those are prepared. But generally, when we know that the patient is going to need NKs, let's say that the patient is coming for the second time, we will do the blood draw right at the beginning of the treatment, and usually in 2 weeks we'll be ready to apply this cell therapy back to the patient. But NKs have improved our stats significantly since we have been able to expand these cells in our laboratory.
Thank you. We're getting a lot of questions, and I really appreciate that, Dr. Contreras. You explained it very well. First question, let's get into it.
Yes.
Let's get into it. And I'm going to go to the first question that was asked by Angel. Does this vaccine work in multiple myeloma after relapse CAR T?
That's a very good question. It should work. Now, CAR T cells are, the next generation of immune therapy. Um, and these are cells that, in theory, should be uh, uh, um, growing constantly in your body. Whereas the cells that we give, they have a lifespan and then they die and they don't work anymore. Whereas CAR T cells will regenerate within our body. So the reason for the recurrence is that somehow the tumor found a way to neutralize the activity of the CAR T cells. So it is not a bad idea then to try our therapy, because it's going to be a new way of attacking the malignancy in a way where the tumor does not know. So I think you would be a good candidate, even though you have been now deemed, or the CAR T cells have been deemed neutralized by your tumor. So yes, I think that we can do our therapy in this too.
Yeah, Angel has a couple more questions, mostly on how long does it take. I think you went through that right now. Usually it takes about 10 to 12 days to expand the CAR T cells. So some patients stay here during the time, the 10 to 12 days of expansion. Some patients go home and come back. But it does depend on each patient individually.
Yeah.
So Angel, give us a call if you can. We have our admissions coordinators currently here at the hospital that you can speak to, or give us a call tomorrow. We'll be happy to look at your case and give you the best recommendation that we can. But it's the first question that we get. The patient has gotten CAR T cells.
Yes.
And then it's kind of asking you about CAR T cells. So everybody wants to get the CAR T cells. Huh?
I'm sure, I don't know if you did it through a trial or you paid for it. And so they're extremely expensive.
Yeah.
It's about $500,000 per treatment of CAR T cells. Because the CAR T cells could be prepared again for tumors that have become resistant to the CAR T cells that you have circulating, and so you could give another. But
that's interesting.
It's just very expensive.
Yes. Well, Angel, please feel free to give us a call. Thank you for that. We're gonna go with Sunny. Does this work for liver mets? I recently met with a phase 1 clinical trial at MD Anderson, and she said that dendritic and immunotherapy doesn't work as well in the liver. She said the liver is known as the lymphocyte graveyard.
Well, the true graveyard is the spleen, but there's no question that the liver is going to cleanse some of these cells. But it cleanses them once they're inactive or once they're dead.
Okay.
It doesn't kill them.
What's the natural lifespan about NK cell in the animal? Is it
it's between weeks, days and weeks. Okay. So, for instance, yesterday I saw one of our patients that came now for the third time with massive liver metastases, and now the metastases in the liver have come down by about 60% after our therapy. So I can tell you that they are effective in liver metastases, and liver metastases is one of the most common metastases for most carcinomas, especially for the breast, the lung, the stomach, the colon, and we have been very successful. So I would disagree that just because these cells are being processed by the liver, that they would not be effective. They are quite effective.
All right. That was a very good question. There's a question. Okay. Roy is asking, what has the success rate been for stage 2 oropharyngeal?
Yes, oropharyngeal carcinoma.
Squamous cell carcinoma, HPV associated.
For alternative therapy such as this, it is not allowed to do clinical trials until the patient has tried everything possible, and then you try something else. And it's usually for stage 4 carcinomas. But we have treated a very good number of head and neck carcinomas, squamous cell carcinomas of the head and neck, and that includes every part, the tongue, the tonsil, wherever in the neck. and they're clumped together because the response is usually the same and the prognosis is usually the same.
Okay.
So in stage 2, in most cases, surgery would be the treatment of choice. I would have to see your case and see if it's possible to remove it or not. Sometimes the tumor is located in an area where it's just impossible to remove. But generally, surgery would be the best option in an early stage head and neck carcinoma. But we've been very successful in advanced stages in head and neck carcinomas. I could tell you that more than half of our patients that have stage 4 head and neck tumors respond extremely well to our impact protocol.
Perfect. Thank you for that question, Roy, and feel free to contact us. Let's go to this side now. Gerard is asking, hi, Dr. Contreras, can you see that NK and immunotherapy treatments options can attack clear cell sarcoma tumors?
Clear cells sarcomas are very rare. We've treated a number of sarcomas, most of them in solid tumors like the clear cell. I don't remember specifically in clear cell, but NKs will attack malignant cells no matter what the source is.
Okay.
So theoretically, it should work. I couldn't give you stats or results because it's just so rare that right now, from the top of my mind, I don't remember even one case that we treated with immunotherapy.
All right, Gerard. Thank you so much for that question, Gerard. Core Advisor is asking, are there any circumstances in which this therapy is not recommended?
That's a very good question. I cannot think of any case where this wouldn't be recommended. No, I don't think there would be any contraindication, except in, let's say, stage 1 carcinomas where surgery would be is the treatment of choice, or
leukemia.
maybe leukemias. Leukemias CAR T cells are much more effective. So they're not contraindicated. It's just not the perfect indication for them.
Yeah.
So the way the question was given to us is it contraindicated?
Okay.
So one thing, contraindicated is when the treatment is going to be bad for you. And not indicated is when the treatment is not going to be sufficient or good for you. So there's a little bit of difference, and I just want to make that.
Thank you for saying that.
So there are no contraindications as far as I know, but there are cases where it's not indicated.
All right. Great question. Let's see, I lost my place. Too many questions are coming in. Janelle's asking, can you do a blood draw and have it overnighted before the patient comes in? No.
You need to prepare the treatment? No,
need kind of like send it over, we'll prepare it, and then no.
By law, it's impossible to cross tissue, live tissue, on any border. So the United States does not permit that, and Mexico does not permit it the other way around.
But either which way, cells start dying.
Right. So there are, some people that give you a vaccine that you can be applying it for months. And so those cells are not going to be alive, okay? Because the lifespan, as I mentioned to you, is
days and weeks.
Between days and weeks.
Okay. Well, thank you for that, Janelle. Yeah, we never had that question before. I love these webinars because all these questions are so good. They're good for us to know what kind of interest a patient has on our treatment. So
yeah, but even let's say that a patient said, "I'm going to send you blood, expand it, and I'm going to apply it immediately." If you overnight it, it's not possible to export or to cross the border. Tissues are not allowed.
Would it be possible if that was an issue? Just quick question.
It would be possible.
Maybe that
if we had a patient like here in Mexico,
So from there, we'll grab the circulating tumor cells.
Well,
And
if the patient
them
sends the
out.
blood,
Uh-huh.
then we can prepare
Yeah.
the product as if the patient
And then
was
the
here.
patient comes in and
then we could send it back. Now, I would have to find if legally in Mexico that is possible.
It's not possible. We already looked into it.
Legally, probably not.
No.
If feasible, definitely.
Feasible, okay. Feasible, yeah. Feasible, yes. Legally, no. Okay,
Yes.
I like that, yeah. Let me see. Patty's asking, does this process kill cancerous stem cells?
That is a very good question, and there are no studies to date showing that the immune system kills stem cells. My impression is that they would not,
Okay.
because otherwise our immune system would kill the stem cells, and the fact is that those stay there. And so an answer, but how would you say bote pronto?
Quick answer.
A quick answer,
Quick answer.
from my experience, is that most likely any product of the impact protocol does not kill stem cells.
Okay.
It may be that they do, but
There's no long-term study on that.
well, there are no studies whatsoever. There's very few studies showing things that kill stem cells.
Okay.
They're complicated, they're expensive, and that's why most people don't do them.
Okay, got it. Thank you for that. Let's see. Does this work on pancreatic adenocarcinoma stage 4 metastasis in liver?
Yes, as I mentioned before, these cells are going to be simulated for the specific tumor that the patient has, regardless of whether it's an adenocarcinoma or a sarcoma or a circulating tumor like leukemias. So, for instance, CAR T cells have been approved for leukemias, but I don't think that even though they're approved, the insurance company will pay for them.
Yeah, I'm sure of that. Yeah. And it's very specific types of stages.
Yes.
And
Yes.
it filters down to
Yeah.
very few patients. Janelle's asking, is this treatment available for first-time treatments, or do you have to do other treatments first? That's a very good question, Janelle.
No, so as I mentioned, generally the treatments are more limited as far as staging than what you have received before. There are certain clinical trials where you cannot give it to a patient if the patient has not received other therapies.
Like chemotherapy already.
Right,
Yeah.
but for clinical trials, as far as ourselves are concerned, the patient that comes to us as a virgin to treatment will have better results if they come to us first. So yes, it can be applied as the first line of treatment.
Perfect. And we do that a lot.
Yes.
Yeah,
Yes.
it's usually kind of reserved for follow-up patients. So we do the dendritic cell and the lymphocyte, the LEKs.
So let me expand this a little bit, because it's a very good question. So normally, when a patient comes to us for the first time, the impact program has about 6 or 7 products. The main products that we use, or the ones that we use more often, are dendritic cell therapy and LACs, lymphokine activated killer cells. So when a patient comes to us for the first time, that's our initial protocol. If that is not sufficient, we start thinking about the other products that we can offer, okay? But there's a caveat. So we had a patient that came for the first time with metastasis to a liver that was transplanted.
Okay.
Patients that have transplants are taking very strong immune suppressive elements so that the patient does not reject the liver. So in that case, we did not start with dendritic cells and the LACs, because the patient was going to need a much stronger immune attack than that, and so we used other elements. But generally, a patient that comes for the first time is going to receive the dendritic cell quote-unquote vaccine. It is not a vaccine, but that's the name that the initiator or the inventor of this
It's a cell therapy.
protocol gave, and it stuck, and it's known as that, and in the lymphocyte activated killer cells. And then depending on the response, we'll give either NKs or any of the other products from the impact program.
Great. Thank you so much. Let's see. Let me go on the Q&A side. Since myeloma is a circulating tumor cell, is this therapy effective for myeloma? I don't know if you were
Yes.
do that, right? Yeah.
Yes, it can be used. Now, again, it depends on the stage, and it depends on what the patient has received. Multiple myelomas respond very well to the new targeted therapies available. And so in most cases, multiple myelomas that used to be treated with very harsh chemotherapies effectively are now receiving only targeted therapies very effectively without chemotherapy.
Okay.
And so that would be my first line, because the response has been so good. And then we can cover the patient with a treatment like ours to repair whatever collateral damage and to strengthen the immune system with our impact protocol.
Perfect. Let me see. Michael's asking results, outcomes for colon cancer metastasis to the liver lumps.
So the in the literature, stage 4, which is anytime you have metastasis, is stage 4, whether you have one metastasis or 100. Okay. So in stage 4 cancer, with conventional therapy, the survival rate, the 5-year survival rate, is less than 20%. The studies will show between 12 and 16%, more or less, 5-year survival rate, up to 20% in most cases. In our experience, we have more than 40% of our patients alive after 5 years. So with our therapy, the life expectancy is at least twice as better than with conventional therapy. So we're very happy about that.
And improving.
Yes,
Improving. Yes, thank you. Being based in Australia, could a treatment plan based on NK treatments be completed in 2 weeks? Yes.
It is possible. Once we know that you're coming, we'll draw the blood basically on the first day that you are here, so that the expansion is ready by the last or before the last day that you have to go home.
Yeah, we're getting a lot of Australian patients.
Oh, really?
Yeah, we are. We're getting a lot more Australian patients. But thank you so much, Gerard. You see, Sunny is asking, do you typically see pseudo progression? If so, when and how do you know if it's working during that period?
That's a very good question. Now, pseudo progression, pseudo means fake, like fake progression, is very common. I would say up to 50%, between 30 and 50% of the cases with any type of immune therapy.
Okay.
So conventional, like Keytruda, Opdivo, the ones that are given in the States or in many other parts of the world, or the cell therapy that we do.
We see a progression of cancer growth or
so what happens is that the immune system recruits cells and it causes inflammation.
Okay.
So you will take an X-ray 4, 5, 6 weeks after, and it seems like the tumor grew.
Okay.
But it hasn't grown. It's just inflamed, and then it will start coming down. And usually the pseudoprogression will last between 3 and up to 6 months, so you have to be very careful. How do you determine whether it's pseudoprogression or actual progression? Normally, when there is true progression, you will have new areas of activity. So let's say that you had 5 metastases to the liver, and you take an X-ray, and the 5 metastases are now larger. Within the 3 to 6 month period, most likely that is not progression, but pseudoprogression. But if suddenly you have 6 tumors instead of 5, then you can assure the patient that that is not pseudoprogression, but that it is progression. And so it's very tricky, because there could be progression without any new tumors. but generally it's going to be
That's a great
pseudoprogression.
rule of thumb in a way.
Yes.
All right. All right. A lot of good questions.
Yes,
This webinar.
very informed group we
I
have
think
here.
some of you are doctors or these health practitioners, right? Sunny, thank you for that question. David is asking, I just had stem cell and exome therapy to improve my overall health. I don't have any disease at the moment, but to be preventative, I would also like to strengthen my NK cells. I mean, it would be advisable as a preventative protocol without interfering with stem cells.
No, I don't think that it's necessary. I think that in your case, stem cells are good enough because the stem cells are going to overall improve your not only your skeleton but your immune system as well. And NK cells therapy, as we've mentioned, I think a couple of times, they have a very specific lifespan, a very limited lifespan, and so it's only going to protect you for those days. Yes, it could protect you, but I think it's too much for so little. When a patient has a tumor, then the attack is going to be massive against that tumor. But if you have no diseases, I do not believe that NKs is a good idea. It's not going to harm you, and it's going to protect you for those days. But I don't think it's necessary to spend that much money on something.
So basically, better investing in overall immune health.
Yeah, and probiotics, exercise, better diet, better lifestyle. I think you're conscious enough, and you're doing enough things to protect yourself already.
Usually that's the case.
Yeah.
Usually that's the case. All right. Great questions. I love it. Joanne's asking, can cancer develop as a result of an autoimmune response? And if so, is impact safe if there is an autoimmune issue? That's a great question.
Yes,
Great
yes.
question. Yeah.
I do not remember reading any article, and I've read a lot about this, where autoimmune diseases actually promote cancer. There are some inflammatory processes that may increase the risk of cancer. And we've treated many patients that have cancer and autoimmune diseases at the same time very effectively with the therapy. So it can be given to a patient that has autoimmune diseases. We are in the process of developing a vaccine, quote unquote, dendritic cell therapy for patients specifically to help them with autoimmune diseases. So there is no contraindication of our cell therapy against tumors when a patient has autoimmune diseases. And again, I do not believe that autoimmune diseases generally will increase the risk of cancer. I would have to review that a little bit more, but I don't think so.
All right. Azem, that's a very specific question, so I'll read it out as slowly as I can. What do you think is the best way of treatment when it comes to low differentiated adenocarcinoma in pylorus? Pylorus?
In the pylorus.
Pylorus, yeah. HER2 negative, MSS, PD-L1, CPS5 with metastasis to the peritoneum, gallbladder, liver, and pancreas. Patient is strong, 36-year-old male.
So low, it says at the beginning.
It's HER2 negative?
No, before that.
Low differentiated adenocarcinoma.
The wording normally is poorly differentiated.
Poorly differentiated, okay.
Okay. So differentiation is talking about aggressivity. The lower the differentiation or the poorer the differentiation, the more aggressive a tumor is. So tumors of the stomach, the pylorus is the valve between the stomach and the small intestine. And so their pyloric cancers are considered gastric carcinomas. Gastric carcinomas are already very aggressive. Poorly differentiated gastric carcinoma is very aggressive, and it's already in stage 4. We have many patients like that. You're very, very young. Chemotherapy has proven of no effect in this type of tumors. HER2 negatives are not eligible to try some of the targeted therapies that could be helpful in this type of tumors. And so I think it would be very much worth your while to come and try our treatment because we've had some success against these very aggressive tumors with our whole approach, the metabolic entity of the therapy and the very personalized immune therapy of our protocol. So you're very young, you're in good shape, and I would urge you to consider the possibility of trying our protocol.
Thank you so much. And Azam, feel free to contact us whenever, so we can take a look at the medical records of the patient and get you a better recommendation. Gia is asking, what is the cost? Does insurance ever cover this? Gia, the cost depends on the recommendation. So every patient gets a different treatment protocol based on their medical records and their physical status and stage. So feel free to contact us. We can get you an accurate price estimate. And unfortunately, insurance does not cover treatment here at Oasis. Many of our patients, if they have international insurance or they have a good PPO, what they do is that they go through third-party companies. One in particular is called Medical Bill Gurus, and they can be reimbursed for some of the treatment that's available here at Oasis Health Clinic. So give us a call and we'll be happy to speak to you about that. I don't know if we went through this. And side effects, did we go through this or?
No.
Is there any possibility of negative side effects?
Yes. The cells are yours, and so you're not going to respond to the
Like a risk of rejection.
risk of rejection is not going to happen. But there's a number of chemicals that are involved in the preparation of this that can cause allergic reactions. And so we have improved this tremendously in the last 2 years in washing the cells and without damaging the cells. So the possibility of reactions nowadays is minimal. And usually the patients may have like flu-like symptoms, chills, that Tylenol is more than sufficient to.
Yeah, and it rarely happens. I mean,
Rarely happens, and especially now. Before we had this new technique of cleansing them, where we had to, for instance, we give 10 million of the dendritic cells, and so we had to divide the 10 millions into 3, and 4
days. Yeah.
So and we would give 1 day in between a chance to see if the patients would have any reactions. Now, with the new techniques, we're able to give 20, 15, 20, 30 million cells in one shot without risk. So yes, there could be some side effects. They're usually minimal. They're related to the chemicals used in the process. And they're generally minimal, as I mentioned before.
Perfect. Either which way, just going back to what we were talking about, we have our own immunotherapy lab here at Oasis, and that's something it's been a passion project for Dr. Contreras for the past, I think, 7 years we've been developing.
Yes.
Opened up about a year and a half ago. And we've seen a massive change because the quality control that we have here at Oasis and ISO certified GCMP techniques. So GMP, I'm sorry, techniques. So everything I've seen a big change in terms of the survival rates and also of any negative like side effects the patient might have, because very rarely do we see a patient stay here longer.
No.
Yeah. So,
and as I told you, there are new techniques. And now we have the equipment to characterize the cell and to identify. Well, first to identify the cell and then character. Well, what does that mean? Well, I can definitely identify that I have dendritic cells. And then I can characterize them by telling you that they're alive and they're going to be effective. So those are the two things. And it's measurable, and so we have the equipment to do.
Yes.
And again, the cleansing protocols that our group that does this, our team, is just
they're spectacular.
first world.
Spectacular, yeah, spectacular. And the development, I mean, we started off with the dendritic cells and the lymphocytes. Now we have the TILs, the tumor-infiltrating lymphocytes. We have the NKs, we have the lysated, and we're at the forefront, the vanguard on this new techniques, this new cell therapy techniques, and we believe it's the future of cancer treatment, to be honest. And okay, continuing on. I hate to be pushy. Can I get a replay of last month's webinar on breast cancer? Yes, you can. You don't. Yes, never being pushy. All of our webinars are on YouTube, so just go to our YouTube page, Oasis of Hope, and there's a on the video page there's a playlist on webinars, so you can. We've done so many of these webinars that so.
And talking about our last one, there was a question by a young woman that was convinced that using the GLP-1,
yeah, I don't have the.
I don't know if it was Opdivo or any of these therapies that are being used to.
Oh, you mean Ozempic?
Yeah.
Okay.
Ozempic. I'm sorry.
Ozempic, yeah.
To lose weight.
Yeah.
And she was convinced that
that was last times. That was last.
Yeah, and the breast cancer.
Yeah, the breast cancer. Yes.
And so I just want to, I promised that I was going to go deep into the literature about this, and I found that generally these peptides will protect people from developing cancer. So the incidence of cancerous people in persons or patients that are using these type of peptides is lower. Only there is one tumor that has increased, and it's in kidney cancer, but the difference is not statistically significant, meaning that it could have been by chance.
Okay.
So for the moment, I can tell all of you that we feel that it's quite safe to use these elements. And in fact, we are studying the possibility of implementing them because the metabolic impact of controlling insulin and lowering blood sugar is actually quite good for a cancer patient. That's why our diets are low glycemic, because tumors take advantage of sugar. And if these elements can help metabolize sugar better and lower the amount of, get rid of insulin resistance, it could be, it could actually be good for a cancer patient, but we're not there yet. But since I promised this patient that I was going to look into it, and I hope that you're watching, for the moment, I feel no concerns in cancer patients using these type of products, and I see no risk in patients that do not have cancer, that the risk of cancer would increase.
That is very interesting. I think you just made a lot of people happy. Controls. Yeah, I mean, so cancer feeds on sugar. Cancer cells have higher number of sugar receptor cells. So if we lower the amount of sugar,
it's not that they have more receptors. What happens is that the cells reject oxygen.
Okay,
they become hypoxic, and a hypoxic cell metabolizes carbohydrates in a very different way, very inefficiently. So, for instance, a normal cell, for every unit of carbohydrate, they will produce 32 units of energy.
Okay.
A normal cell, in the presence of oxygen. When oxygen is not there, a cell will produce for every unit of carbohydrates 2 units instead of 32.
Okay.
So that's why malignant cells become bullies for sugar.
Okay. So no more. No. Okay.
Because they produce very little energy, so they need 32 times, not 8 times, or so 8 and 20 times more.
Got it.
Sugar to produce the energy that they need, and that's why they love sugar. The term has become they love sugar. They don't love it. They need it like crazy.
Got it.
So these new type of peptides that metabolize carbohydrates in a much more efficient way may actually be good for a cancer patient. And that's what we're looking into.
I like that's interesting. Let me see. So many questions. We're gonna start dipping it up a little on the questions.
Meaning I should not speak so.
Not, I didn't say that. I didn't say that. we just go. They're good questions, and we learn a lot actually from these questions. Can you treat a cold tumor MSS colon cancer stage 4?
Yes. Now MS is
Oksana.
so these tumors, unfortunately, because it's so specific. So mismatch. What that means is that the DNA of these tumors are very unstable. And the more unstable a tumor is, the more that it's going to mutate, meaning the cancer that I was treating yesterday is going to be different. Well, today it's exaggerating, but in a short time, the tumor is going to mutate. Okay. The more unstable the DNA of that tumor is. And so our treatment, regardless of the mutations, the immune system is going to detect the tumor itself. And so, yes, it's very well indicated, especially in very aggressive type of tumors that may change, where they are going to not be, where the treatment that was effective and the next mutation is not going to be effective. That's what it means.
Okay.
And so it's scary because you run out of options.
Yeah, of course. Hey, I have a lot of questions on that, but I'll continue. Does the NK cells kill good cells as well? No.
They're very specific to kill tumor cells, viruses, and some inflammatory cells.
Okay. Can this be done after 6 rounds of chemo?
Yes. It doesn't matter how much chemo you've received.
Len is asking, is this treatment safe for alpha gal patients?
Alpha?
Gal, alpha Gal. Gallbladder or?
No, I imagine that it's a mutation. I have no clue what it is.
Okay.
But I'll look into it. Or maybe you can write a little bit more about what that means.
Okay.
And then we can tell you now.
Yeah, Linda, if I don't get to your questions, please feel free to send us an email at info@oasisofhope.com and we'll get back to you as quickly as we can. Captain Wright says, my husband did Dendritics. And Rachel says, I love that. I'm so glad Rob didn't have other therapies before coming to Oasis of Hope. Rachel Clausen is Rob Clausen, you remember, is one of our patients. Janelle's asking, how many treatments are usually required?
That's a very good question. So we usually are going to at least require 3 treatments. The first treatment is given when the patient comes, and then 3 months later, generally we give the second therapy. Depending on the result, we may prolong that to 6 months. And then if the patient is stable or has responded very well, then we'll do it once a year for 5 years. And if a patient is completely stable at 5 years or tumor-free, then we graduate that patient.
Perfect.
It varies quite a bit depending on the aggressivity of the tumor, the amount of tumor. We have some patients where we're giving the vaccine every month because the tumor is so aggressive or so massive. But generally, it's a vaccination every 3 months for 6 months, and then every 6 months for a year, and then every year for 5 years.
Perfect. And hopefully we'll have the cryopreservation frozen, the frozen cell therapy soon, and that's coming pretty soon. So we'll have more information on that when it's ready. Where are you located and how do I contact you for more information? Rosa, I was diagnosed with stage 4 NSCLC. So Rosa, we are located in Tijuana, Mexico, which is a Florida town with San Diego, California. Most, if not all, of our patients that come from abroad, they fly into San Diego, California. We pick them up at the airport, we bring them down to Oasis, and they stay here inpatient for about anywhere from 2 to 3 weeks at a time. So give us a call. Our number is it's a U.S. number, 619 619-8450. That's 619-690-8450. Or easier, just go online to oasisofhope.com and fill out one of our contact forms, and one of our admissions coordinators will contact you tomorrow. For everybody, anybody that wants to get in touch with us, please go on our site, or call us, email us. And what we always do with patients is that we speak to a patient about their condition, and then we ask them to send us their medical records, their most recent medical records. But it has to contain a pathology report, any kind of imaging, doctor's notes, lab testing. So the more information we have, the better recommendation we can give. But we do offer free Zoom consultations with our admissions doctors once we receive the medical information necessary for us to make an appropriate recommendation. So we have about anywhere from 4 to 18 calls a day. So give us a call, and we'll get you scheduled.
And as far as your diagnosis, non-small cell carcinoma, there's two big branches of lung cancers: the small cell and the non-small cell. Fortunately, the non-small cell is the less aggressive. They're both very aggressive. But small cell carcinomas are a lot more aggressive. And yes, we've treated many patients with non-small cell carcinoma of the lung.
Perfect. All righty. If Angel's asking, if a patient has already been in remission from acute lymphoblastic leukemia with a bone marrow transplant and the cancer returns, can this type of immunotherapy be performed?
Yes.
Okay. Yes. Let me see. Michael's asking, would this work for choroidal melanoma of the eye?
Yes.
Yes.
With a caveat. If you were just diagnosed, treatment with conventional immunotherapy for melanomas is very effective. And so if you have insurance, I would probably recommend that you do that first, and most likely the problem is going to be resolved.
Okay. Ruth is asking the most famous question that we get asked on a regular basis: why is natural killer cell treatments not available in the U.S.? I think they are available still clinical trials.
Yes, there are a number of clinical trials available in the States. And the main reason is that there's very little money to be made in individual therapies. And so in America, they want to convert this into a drug therapy. So they are trying to develop a dendritic cell therapy for cancer of the breast, where you can pick it up from the shelf and say, you have breast cancer, I'm going to give you this.
Kind of like a library of.
Yes.
Oh, okay.
And I don't think that's going to work. It's going to take a long time because they're in the trials of doing first efficacy and then security is not safety. And so it's going to take a long time, and I don't think that it's going to work. It's available in Mexico because these are individual therapies that have proven to be effective, and we don't need to do safety testing, which is expensive and takes a long time, because it will never be given to any other person than for the person for which the therapy has been developed. So there are no safety issues whatsoever. And so the Mexican government has opened the door for immunocell therapy, and we're very happy about that. And so we have people coming from all over the world for this therapy here in Mexico.
Okay, we're going to get very specific for Leona. Dr. Contreras, I had triple negative breast cancer stage 3 in the spring. I had a mastectomy and a lymphectomy. On right breast, I think it would be. Yeah. No chemo, no radiation. I went to a 2-week treatment center in San Luis Rio, Colorado. I received various infusions, dendritic cells, etc. The treatment they started and sent me home to continue. The treatment they started and sent me home to continue is called CAAT, Cancer Antigen Antibody Therapy, which I imagine is kind of like a clinic like ours, but it's in San Luis Rio, Colorado. I self-administer shots every 3 days. I realize this may not be exactly the same as your treatment, but does this sound similar to your cancer immunotherapy? Not really.
No, not really.
Not really, no. There's a lot of treatments. I mean, I do a lot of research on other centers, and a lot of people claim they do dendritic cell therapy. But when I read on the literature, it's kind of like they take it home with them, which is
It's not.
I mean,
then it is not what we're doing.
Not what we're
because
doing,
we're
yeah.
giving live cell therapy.
exactly.
There may be a way to produce a therapy of just antigens, and the antigens are the ones that are being injected constantly. If you're doing fine, continue with it.
Yeah, exactly.
Because triple negative breast carcinoma is very effective. You did the right thing in not taking any chemo or radiation, because it usually just makes the things worse. And so if there are any red flags, let us know, and we'll be happy to help you. We have a lot of experience with that. But if you're doing fine, then continue with the therapy.
All right, cancer antigen antibody therapy. I'll look into it.
Yeah, so I think it's just the
Just the name,
antigen.
yeah,
Yeah, but they're just giving the antigen.
the antigen, but
And that's not bad,
Not
okay?
bad.
Well, there's a part of our therapy where we just give antigens.
but yeah,
So it could be a
but
good
they have
thing
to
that
they have to isolate the antigen first
yeah.
individually.
Well, you can isolate the antigens from tumor circulating cells, but to have such a big amount to be fractionating that,
And then
if they got it from tumor tissue, then yes, the possibility of obtaining a vast amount of antigens,
paraffin blocks or from an actual tumor biopsy.
either way.
Okay.
And then, yeah, you could probably produce fractions for a long period of time.
They have to be frozen?
No,
No? Okay.
not that I know.
Okay. All right. It's 5. So we're only going to take 2 more questions.
Okay.
And that's it. But I really want to thank you guys for your patience and for standing and for sticking with us. It's we have so many questions we have to get to. All right. Let's see. Does this treatment work well with aggressive, fast-spreading cancers? Josiah is asking.
Yes, as I mentioned before, even in gastric carcinomas, pancreatic carcinomas, which are 2 of the most aggressive cancers there are. So yes, it can work in fast-growing tumors.
All right. And the last question is, if you have proton radiation, Madeline's asking, if you have proton radiation for lung cancer and come to Oasis after for breast cancer, the patient has breast cancer, is doing proton radiation for lung cancer, and wants to come to us after their proton radiation, would the radiation interfere?
No, especially with proton beam. Proton beam is the least aggressive of all of the radiations available. So yes, it will not preclude you from receiving our therapy.
All right, Dr. Contreras, I want to thank you so much for your time. I know you were freezing, and I feel bad because I'm freezing too. But we powered through it, and I want to thank you, everyone that was a participant in attendance here on our first webinar. We're gonna have another webinar in 2 weeks. And the next topic is going to be on our metabolic side. We're going to focus on ozone therapies, EBU, autohemotherapy, and saline ozonated therapy. And that's going to be very interesting.
And let's bring some of our experts in that field.
Let's do it. Let's do it.
That are very, very keen on the subject of ozone therapy.
Yes. And we're going to give, how many books do you want to give out this time around?
Let's give 10 books.
10 books. So of all the participants, we will send you an email, and if you get an email from us, send us your name and address, and Dr. Andres will personally dedicate a signed book for you guys on his latest book, The Art of Undermining Cancer. And Dr. Andres is going to hopefully come up with a new book called
very soon. Exactly, very soon.
That we're working on it now, and the date of our next webinar is in 2 weeks, so that would be on the 20th. The 20th. So we'll have that up on our website. And there,
Is the 20th Thanksgiving?
no, the Thanksgiving's on the week after that. So the Thanksgiving on the 27th.
Okay.
Yes, we won't keep you from your family
Good.
that long. So thank you so much. This webinar will be available on our YouTube channel tomorrow. Just give us a chance to edit it, and also on Facebook, and the snippets of it will be on our Instagram. I want to thank you all again for joining us tonight. Wherever you are in the world, may God bless you. May God keep your family safe. We send you big hugs, big love from Tijuana, Mexico. And thank you so much. So we will see you in 2 weeks. Thank you so much.
God bless.